It's my pleasure to invite Gary Pess, and we are looking forward to his talk. Thank you.
Good afternoon, everybody. I'm honored to be here to share my 40 years of treating Dupuytren's, 21 years of doing PNF, and 16 years of doing collagenase. We're going to talk about my approach to minimally invasive treatments and some tips and pearls. These are my disclaimers. Wolfgang said earlier, or at least alluded to, that the patient is our purpose. That's what we're here for when we treat patients. And I strongly believe there should be a paradigm shift away from waiting until somebody has a contracture for 30 to 45 degrees and then doing an open or limited fasciectomy. I think we need to treat early, we need to treat minimally invasively, and we need to treat recurrences early before arthrofibrosis sets in, and again, trying minimally invasively. These are some general principles that go for both PNF and collagenase. You need to be sure that a cord is present. Neither of these techniques are useful for scar. You're releasing a cord causing the contracture. Patients should have reasonable expectations. I can't say how critical that is. No, the nodules are not going to be removed from your hand. No, you're still going to have some lumps. It's really, really important. And again, I emphasize it's worth it to treat early, especially PIP joints. Find the best areas to release the cord. No matter what technique you use, you're looking for areas of supple skin, not inflection creases. Look for an area of maximum bowstringing, which can be increased by extending the finger passively. Cords are very superficial, 2 to 4 millimeters beneath the skin. You're not diving deep for either technique. And we have the advantage as surgeons, having done so many open surgeries, that we can try to visualize the three-dimensional anatomy, even though we're doing a procedure that's blind. Though I think we're going to learn a little bit in the next talk, there's another way to see some of the anatomy. Some tips and pearls. I'll start with PNF. That's my weapon of choice, a 25 gauge, 5/8 inch, 19 millimeter needle. That's the little blue one. In the EU, I believe it's gray. I use intradermal anesthesia, so I put a small amount of local in the intradermal area. We're not anesthetizing the neurovascular bundle. We're making sure the patient can feel and respond to me and let me know if I touch the nerve. For bad contractures greater than 50, 60 degrees, I inject the PIP joint with local. I change my needles frequently. If I feel like they're dull and they're not cutting the way I'd like them to, just toss it out, take another one. They're relatively inexpensive. Usually the portals are in the center of the cord, though for wide cords, 5 millimeters or more, side-to-side portals, as you can see in the picture on the right, side-to-side portals. There's a pinch and poke technique, pinching the cord, placing the needle between my fingers. It helps if you have an assistant, but if not, I can lean the ulnar side of my hand and hyperextend the finger with a gentle extension, tension to bowstring the cord up a little bit. I angle away from the neurovascular bundle. You can put it in any angle you'd like. It does not have to be vertical. Try to angle away from the neurovascular bundle. The nerve is your enemy in PNF. The nerve is the enemy that you're trying to avoid. Sometimes you can grab the cord with that pinch technique, put the needle in, and actually move the cord rather than the needle. And I find in some cases that's really, really tricky and helpful. So I'm pinching the cord, needle's in, I feel it's in, and I'm moving the cord, which limits the ability, the likelihood of damaging anything. Massage cords when you're done, especially small lateral cords, natatory cords, massaging with your thumb can get that little more bit of crackling to go. You've done releasing the cord. You think you did a great job, but there's still some residual PIP joint contracture. I believe there's a non-palpable cord centrally over the PIP joint, middle finger crease, that needs to be released. You're trying to release it just proximal to the middle finger crease, superficially, not entering the flexor tendon sheath. And sometimes that's enough to get that PIP joint to pop open. You're staying very superficial and central. you still have a PIP joint contraction. Look for a hidden retrovascular cord. You can see the picture, the white arrow on the left. That puckering is a retrovascular cord. I've released the finger, but I still have about 20 degrees left. And I marked it on the right side, and those are the portals. I enter, usually one portal is enough, angling dorsally away from the nerve, and it can release that cord nicely. And that, you'll get a nice little pop. It's very easy. You don't need to go in multiple places. I just marked it out with dots just to show you. Subcision can be useful. I use sometimes an 18 gauge needle for this, but I use the same 25 gauge needle, bend it 45 to 90 degrees, place it under the skin at the creases to release the cord from the dermis. So you're basically freeing up the skin, which allows more skin mobility, decreases the chance of a skin tear, which is not that big a deal anyway, but it helps release it. It's superficial over the creases, usually centrally. Boutonniere deformity. We saw some good cases presented earlier of fixed boutonniere deformities. When someone has a fixed boutonniere deformity, hyperextension of the DIP joint that does not passively flex, I release the terminal extensor tendon over the neck of P2. I usually go in radially, do half, go in only, do half, and you can usually get it released, passively flex the finger, then ask the patient to flex it, extend, and you can see the improvement, the left side compared to the right side. I'll talk about this a little bit further later on. Here's a case, quick case of a PNF. Thumb IP joint 43 degrees, ring PIP 44, little finger 5262. It's a fairly significant contracture. And this is the type of result. Is the IP joint of the thumb perfectly straight? No. For some reason, that scars, that IP joint of the thumb, if it's been, you have an IP joint contraction for a long time, it's very difficult to get perfectly straight, and I'm not taking a chance that I cut the radial digital nerve of the thumb. But very satisfied patient, good proms on this one, and fairly good release in the hand. This is a 75-year-old with a 78 PIP and a 33 DIP, nice, long ulnar cord. And here's a video. It's working. I have one more video. I usually start proximally and work distally, especially if there's one long cord. Because if you can release the cord proximally, then when you go distally, where it's more dangerous and the distance between the cord and the neurovascular bundle is so much closer, it's easier to release. So generally, I'll go proximally, distally. If there's separate cords, I might go distally to proximally. It looks jerky. It's a 30 frame per section video, but I assure you that I'm being gentle. You can see I'm pinching the cord. Nobody's holding the finger except me. I'm hyperextending the finger. Watch his thumb. This patient's awake. You'll see that thumb flex every once in a while. It's not completely painless. So I've released, the MP joint is, the PIP joint is just about completely released. And I will go up the finger. It looks, I hate these videos because it looks so jerky. But and look at the distance between the needle and the skin. I'm not diving in. I'm maintaining that space between the hub of the needle and the skin. It's the same thing for collagenase too. You do not dive in. If you dive in, that's when you can cut the digital nerve. Now, this is subcision, this puckering over the central portion of the finger, just proximal to the crease. I'm using subcision to release that skin, and at the same time, I'm releasing that non-palpable central cord. His DIP joint is pretty straight now. PIP joint is not as good as I wanted it to be. So I go back proximally, feel the cords again, see if I missed a cord. I use my thumb to massage, just like I taught. I found one other spot that maybe had an extra cord, or maybe I didn't release the cord completely. And now, full fist. We saw that great case that Tim just showed, where you change the arc from a bent hand to a hand that's straight but can't flex. We do not want that. We want the hand to be as straight as possible, but to be able to be fully flexed. Absolutely critical. Some tips on collagenase. Carefully explain the side effects. There are a huge amount of side effects. They're normal with collagenase. you must go over them with the patient, especially lymphadenopathy. I use two vials most of the time, as long as there's more than one joint, and I used 2 full doses. Nothing goes in the garbage. If I'm paying $5,000 for a vial, I'm using every bit of that enzyme. Confirm that the XIAFLEX is in the syringe when you pull it up. I've watched people do it, and they drew up air, and they're about to inject air into the hand. Trust me, it will not work. I use anesthesia for the injection and for the finger extension procedure, 10 to 20 cc's, ulnar nerve block, median nerve block, digital nerve block, PIP block, dorsal sensory branch of the radial nerve, dorsal sensory branch of the ulnar nerve, whatever I got to do so that we don't hear, as I think Professor Sagerschmidt said earlier, screaming from the room next door. So I'm trying to eliminate that. Maintain tension on the cord, stay superficial watching the hub, pinch and poke technique again, angle in the safest way. If you penetrate dorsally through the cord, do not pull back and inject. Pull back and find a new spot in the cord. You don't want to inject dorsally. The flexor tendon is your enemy in these cases. The portals, a variety of portals. The original description by Hurst in New England Journal of Medicine was, one spot, 3 portals together. Forget it. This is needle aponeurotomy technique. This is PNF technique. Divide the aliquot up as much as you want. The top one on the right is a T. That's good for a very wide cord over the proximal phalanx, which I like to do collagenase for because they're difficult to release with needle. A box on the bottom left, and I inject distally in the fingers as well, as long as it's a small amount, 0.03, 0.02, and aiming away from the flexor tendon. Manipulate after 24 hours. Again, lots of anesthesia. Sorry for the blood, but these do tear. The skin tear rate's 21% with two vials published. And if you see an area blistering, bruising, cover it with a gauze, then do the finger extension procedure, and you won't get blood on yourself, the patient, or your ceiling. And trust me, I've had them all. Manipulate the finger in extension, flexion, pronation, supination, adduction, and adduction, and don't forget to manipulate the finger next to the one you're treating, because there's those cords that go from the ring finger to the little finger. You can pop them easily when you do it. Here's a 7-year-old 5333 ring, 4148 little finger. Nice result. MP and PIP joints in adjacent fingers. This is a little finger 5729. Nice result. You can see the bruising. And this is a little 2-second video. 84-year-old ring finger PIP joint, 79 degrees. I don't know if there's sound. This one has sound, but whatever. Inflection to take the tension off. And we're going to gently try to extend his PIP joint. I would put a gauze over this today, because that's pretty bruised. Listen to the patient. Make a fist.
Keep it.
Open up all the way. Make a fist again. Open up all the way.
Well, that only hurts when you do that.
Beautiful. The patient is amazed. Again, what Wolfgang said, what Anna's taught, patient is our purpose. This is a happy patient with a good result. That's why we're here. Complications, pain and swelling, sensitivity, ecchymosis, skin tears, very common. Serious complications, nerve injury, usually for PNF. Temporary neuropraxia is fairly common for bad contractures, 75 to 95 degrees. Tendon injury and rupture, a fear that you have with collagenase. But the published rate is very, very low. Maybe we're going to hear a little bit about that in an upcoming paper. Infection, I've seen 2 infections in 21 years with PNF, and both were superficial. Post-op care, I splint. I'm a splinter. And the recent Journal of Hand Surgery article, May this month, showed statistical significant difference for splinting for PIP joints. Did not show for MP. Skin tears, local wound care only. No skin grafts, no flaps, no artificial garbage. Hand therapy I utilize all the time, especially for residual contractures that I could not release safely, and for an active extension leg of the PIP, what we heard earlier. a stretched central slip. So I'll use dynamic splinting for that. This is a case that I wanted to bring up, and it was really, really nice that it was brought up earlier today. This is a yoke splint, relative motion splint. If you look at that finger on the top left, that's the patient trying to actively extend the finger before I release them. On the top right middle, that's them actively extending the finger after I release them. This is perfectly straight passively. And what happened is they're hyperextending their MP, which laxes over the PIP. So these are patients I use a yoke splint or relative motion splint, as described by Wendell Merritt. Unsolved problems. Little finger PIP joints. Little finger PIP joints. It doesn't matter what procedure you love, highest recurrence rate. I also think it's not reported often because there aren't that many, but index finger PIP joints are awful as well. Fixed boutonniere. I showed you how beautifully I released it with the needle. I can do the same thing with collagenase. That's great, but it recurs. Definitely an unsolved problem. Joint contracture, arthrofibrosis, you can't release it with either. And stretching the finger, there's a limit to how much you can stretch. Also, patients with rapid recurrences, thick disease, it's probably a different biology. Some words of wisdom: don't go for perfection always, just go for improve. Learn your limits, try not to break the finger. Practice to improve your skills, and continuing education is critically important. This is our treatment goal. Take a finger that's crooked, bent, disabling, and try to get them better. These are two pretty severe contractures. This is what we're trying to do for our patients. In conclusion, there is no cure for Dupuytren's. These minimally invasive procedures can be performed successfully, even with severe contractures. Until a genetic or disease-modifying treatment can be found, consider trying minimally invasive treatment first. I want to thank you for inviting me to speak today. As Dominic and Ilse both said, the 2010 meeting was a stimulus to us younger surgeons at the time. Yes, they're somewhat younger. I've made a lot of great friends at these meetings. We've collaborated and written many papers together. This is a brother and sisterhood that I love. And bottom left, bottom right, cheers to hopefully finding a cure someday.
Thank you very much for this wonderful talk. There are questions.
Gary, I really enjoyed your talk, and you've taught me a lot about minimally invasive treatments for Dupuytren's. But how do you counsel a patient when to use collagenase versus needle? If cost is an issue, so preference of the patient.
And Mark, it's almost $1 million question without any question. I try to explain the difference between the two, and I find that I do treat a lot of patients that come from far, and some of them are pre-chosen. They come to me, they want PNF, it's done. I don't discuss anything else. But for patients that come that aren't far and they're local in my geographic area, I'll go over the recovery, which I think is a little bit longer with collagenase. I'll go over the side effects. I'll go over the pain difference. You know, being in the OR one day, but the needle can be somewhat painful, and try to let them decide. If someone has a really thick, wide, big nodule over the proximal phalanx, I'm going to try to push them toward collagenase. But otherwise, I believe that patient education is important. I try to educate them before they come, so they can think about it before. And with social media today and the great, British Facebook group that we have and other groups on, I think people, pretty much when they get there, they've kind of made up their mind what they want to do. But I do try to guide them and educate them.
Over there, yes?
What do you think of dry needling? Could it be something that can be used as well for treatments?
I'm sorry, I didn't hear the question.
What do you think of dry needling?
I don't have any experience with dry needling. I mean, I know that it's done, around the world. I think that if you're doing dry needling and using the needle and actually releasing the cord, you're doing PNF. If you're just dry needling a nodule, I'm not sure it makes that much of a difference, but I think we do need to see some studies and maybe some data on dry needling and see how it's the same or different than PNF.
Yes, please.
Gary, we change our thoughts, and we agree that more should be done for the single finger problem, either being digit 5 or being 4. And having a recurrence after your first surgery, you question how you would approach this problem. All other fingers are stage N. The other one is maybe stage 2. And you know, with me and with discussions, that we treat these patients with a special way. We publish the data in a poster form at the ASTRO. And the idea is that we give a post-op radiotherapy within a week if it's fasciotomy. And you see about 4 weeks if it's healed fasciectomy. This finger will receive only 1 series of radiotherapy, like a keloid, which is successfully treated. And the remaining, they will receive 2 series because they are prophylactic. And the results are excellent. We are now 5, 6 years data out. It's certainly a phase 1 to 5. But isn't this an idea you also follow with your radiotherapy?
When I have a recurrence, especially a fast recurrence, I will treat minimally invasively again and definitely give the patient the option or try to push them to consider radiotherapy to try to prevent a recurrence in the finger after I've straightened it again the second time, and also treat the surrounding area to try to prevent those areas from likely contracting.
We have a poster here today where we've sandwiched, or I've sandwiched, collagenase treatment between 2 phases of radiotherapy, and the results are very good.
I've treated patients with radiotherapy that have had radiotherapy. I've treated with needle. I've done needle and then radiotherapy afterward, and collagenase, the same thing. So we've had them both sandwiched or before or after.
Just explain something else to me, please, because I may have missed it. When you do your needle aponeurotomy, do you have saline in the syringe?
If the patient is not diabetic, and we heard the high incidence of diabetes with Dupuytren's, I have it's a 5 cc syringe, 3 cc's of 1% xylocaine plain, and 1 cc of Depomedrol, 40 milligrams. That's the kind of yellowish, the whitish color that you see.
Just explain, what was the significance that the person asked about dry needle and wet needle? What was that about?
I mean, dry needling is a totally different technique. It's almost like an acupuncture or a therapy technique that people use. I'm not an expert on it, but it has nothing, if it's done like needle aponeurotomy, then it's needle aponeurotomy. If it's just sticking needles in it, it's more like an acupuncture. Yeah, different ballgame.
Doesn't come under your expertise.
Last question.
I'm not sure I hear you. I've had CRPS, like everybody else has, but since I went to minimally invasive treatment, I cannot think of one patient that has had. That doesn't mean they won't, because if I cut the digital nerve, that increases the likelihood of it. But I think the difference between open surgery with the swelling and bruising, post-op recovery and difficulty, the incidence is much higher. And I have done PNF and collagenase on patients who have previously had CRPS after a distal radius fracture, and blocking them and doing all the things that we do seem to prevent it. So nothing is definite, though. That's just my experience. Thank you very much, everybody.